Good evening. My name is Sandeep Gidvani, so I'm here today to give you guys a lecture on neck or back pain or both of them together. So thank you all for coming today. This talk is sort of the beginning of a lecture series given by the hospital, so I don't know if anybody from the hospital itself is here, but thank you guys so much for letting me give this talk today. I am a spine surgeon in the community. And so my goal here is to basically provide some education today to you on both neck pain and back pain, okay? What I'll do is sort of talk about neck pain first, and then I'll move on to back pain in between. I'll stop so that if you have any questions about neck pain specifically, we can address them, and then move on to the next topic. All right. So my quick disclaimers are that I don't have any disclosures or conflicts of interest with respect to this talk. And secondly, it clearly does not cover everything that may be responsible for your pain. So unfortunately, I just can't do that in an hour. Okay? Okay, so the objectives of today's talk are basically to cover various causes that may be responsible for both neck pain and back pain. I try to make this talk personal, so what you can do is look at the areas that are highlighted in red. The question that you can ask yourself when you look at those areas is, how does this relate to you personally? So it'll help you establish a diagnosis. So in each of those slides where I talk about one of the neck pain or low back pain diagnoses, there's a section to the right lower corner where it talks about specific symptoms. And so that's where you would look to see if you have any of those things. Okay? What can you do to treat your pain? Well, definitely we'll touch on those things at the end, but the goal of this is more to orient you to these diagnoses so you can sort of understand if you yourself or any of your close friends or your family members might suffer from one of these. Okay? So we'll just start with some basic anatomy of the spine. So the spine is divided into three major parts: the cervical spine up here, the thoracic spine through this area, and then the lumbar spine down below. So that's your neck and that's your low back. Okay? The normal curves that should be there are, it should curve forward at the top, it should curve backward at the middle, and then back forward again at the bottom. Okay? So that when you look at yourself from front to back, you should be nice and straight, and when you look at yourself from the side, you have a nice S curve. Okay? When we start with the neck, we talk about the cervical spine. So the cervical spine has 7 vertebrae in it. C1, 2, 3, 4, 5, 6, and 7. C1 is actually a ring vertebrae. Okay, it sits around the top. It's called the atlas. C2 is the axis. Okay, so there's sort of a pointing portion here. C3, C4, C5, C6, and C7 are individual vertebrae. And you see pictures of the atlas and the axis here. So we'll talk about this in a second, but when we talk about motion, so when you get motion from your neck, when you look around, look up and look down, look right and look left, those come from actually the top of your spine. So you get flexion and extension from where the skull hits the C1 ring. Okay, that's how you get your motion of looking forward and looking back. You actually get a lot of your rotation from side to side from where C1 articulates with C2, and it's actually this little joint right here, okay? That's called the atlantoaxial joint, so it allows for side-to-side motion. And then you get some remainder of that motion from the soft tissue structures between the bones. Those are the discs, okay? And so what's the purpose of the cervical spine? So it serves to support the head, okay? Obviously, it's the next component of the spine below the skull. The skull's weight rests on it. In addition, it protects the spinal cord. So you can see here, this is the basic outline. There's the bone or the vertebrae up front, joints towards the side, arteries run through here, and then this central area is where the spinal cord sits. So basically, it houses or protects the spinal cord. Okay, we talked about this a little bit already in terms of motion. The cervical spine does allow you for movement. One is flexion extension from the skull to C1 articulation or joint. Rotation is from the C1 to C2, and then you get some lateral bending from side to side. That's a component of, from your spine's perspective, from the discs, but also your muscles allow for that from side to side. So neck pain. So neck pain's different for everyone, okay? Some people can have one-sided pain. Some people have it across the back of both sides of their neck. Some people have stabbing pain that comes on all of a sudden. Some people have dull, achy pain that's there all the time. Some people have pain associated with their neck that goes down their arms. We call that radicular pain. Radicular meaning, not meaning that it's ridiculous, but radicular meaning that it's radiating down your arm. Okay? And acute Acute means that it came on just a few days ago. It only started recently, whereas long-term or chronic means it's been there for a long time, and there may be some chronic component to it. Okay? Other symptoms that we look for when we talk about neck pain are things like headaches, weakness, numbness, and dizziness, and we'll get into that a little bit. So how do we diagnose neck pain? The first basic test that I get in my office is an x-ray. Okay? It gives me an idea of what the structure of the spine looks like in the neck. It shows you all the bones, the skull, and sort of the alignment that you have. Next, we then look at an MRI. The MRI is a great study for the soft tissue structures. Usually if you're looking at a neck MRI, you can see the base of the skull, right? This is the base of the brain here. Then you see the brain stem is this shape right here, this gray shape. And then as you follow this ribbon-like structure down, that's the spinal cord, okay? In between these bones that we saw on the x-ray are where the discs are. And you can then see the disc structure, make out what the integrity of it is. And then you can also look at the spinal cord and how the disc is affecting the spinal cord. CT scans are a very fine, detailed way to look at the bony anatomy of the spine. Okay, so if we're looking for specific bone spurs to see if they're pressing on the spinal cord, or if there's a big disc and bone complex, we can get a good idea of what it looks like more so on the CT scan. So some of your doctors may order that as an adjunct to their MRI. And then fourthly, there's a bone scan. So you can get a bone scan often in the situations where you're looking for either infection or you're studying a tumor or suspicious of a tumor being present. Okay, so now we're going to talk about what are some potential causes of neck pain. So the obvious ones are things like strained muscles, right? Strained muscles or ligaments. Oftentimes people use the term whiplash. That basically equates to muscle strain from a car accident. Okay, trauma can definitely cause neck pain, or head and neck pathologies can cause neck pain. Now, typically speaking, when people come into our office and say, I have headaches and I think it's coming from my neck, it's not likely coming from the neck. Okay, there are rare cases where pain can radiate upwards. That's mostly the higher nerve roots like C1 and C2. But for the most part, headaches, you know, as a spine surgeon, I'm not necessarily studying these things, but I often tell the patient, well, you might want to think about things like TMJ. You might want to think about nerves in your brain stem, such as the trigeminal nerve that comes across the face and provides sensation. Some people have a trigeminal neuralgia. So those things can overlie and confuse patients into thinking, well, it's coming from my neck. Not always the case. Then what about specific spinal pathologies? So these are the diagnoses we'll go over next. So things like degenerative disc disease, herniated discs, cervical radiculopathy, okay, referring to pain radiating down the arms, cervical spondylotic myelopathy, 3 big words which we'll talk about, you know, how that makes sense, and then cervical stenosis or congenital stenosis. All right, so let's start with the most basic of diagnoses, that is degenerative disc disease. Now this is a big fancy term for basically the word osteoarthritis in the neck. Degenerative disc disease is a spectrum, and the same applies for the neck as it does for the back. You can be early in the spectrum, so somebody may tell you you have mild arthritis, or you may be far along in the spectrum and have advanced arthritis. So that's why it falls into a spectrum. Basically what happens is this disc structure that sits up front is composed of a central jelly nucleus and then rings of collagen that surround it. And as that disc tends to break down with normal wear and tear, normal walking around, or even sort of loading exercises, especially if you were a football player when you were young, if you had a lot of contact activities, you can wear out your disc obviously at a faster rate because you have more loading. So typically the symptoms or the disease process is described as the loss of the normal tissue structure and function as a result of the basic aging process. Okay? What do you feel? Well, this is the section I talk about in terms of relating your symptoms. You feel neck pain. It may be localized to the neck alone. It does not necessarily go down your arms. You feel stiff. Maybe when you wake up in the morning, first thing, your neck is really sore, and as you walk around, move around, do the normal activities of daily living, and look to the side, look down to the ground, you tend to loosen up. That's pretty consistent with arthritis. Okay? You may have some soreness, some muscle fatigue, and you may be limited by movement if the arthritis or degenerative disc disease is quite advanced. Okay? Now, what about a herniated disc? Well, in the cervical spine, it becomes a worry because what's sitting directly behind the disc? The spinal cord, right? But the disc can occur, the herniated disc can occur at different places. So one would be centrally where the cord is, the other would be out to the side where the nerve roots are exiting out, okay? So basically a herniated disc is defined as an extrusion of that central jelly tissue through the annulus or the outer rings, and as a result it may place pressure on either the spinal cord or the nerve root that exits here. Okay, so at every level in the spine, remember I talked about, I named the levels, right? C1, C2, C3. At every level, you have an exiting nerve root that comes out on either side, okay? And each of those nerve roots are like electrical wires. They go and do a specific function. So for example, if you think about the wiring in a circuit, right? They say the red wire sets off the alarm, the green wire gives the go signal, the blue wire is the one you cut to turn off the thing from working, right? If you think about wires like that, well, you think about nerve roots the same way. Each named nerve root goes to a specific section, okay? So for example, the C5 nerve root is typically innervating the deltoid muscle, which allows you to bring your arm up like this, okay? The C6 nerve root typically innervates the biceps, so that's this function, and so on and so forth. So when we see something like this, where the disc is pressing on the nerve root, then we say, okay, where is this in the spine, and does it correlate with what the patient is feeling, okay? So typically the symptoms associated with it are neck pain, arm pain in a specific location, and then signs of cord compression. And this is what we'll get into in a bit, but if you have enough of a disc, herniated disc, if it's large enough, you can actually compress the cord. When you compress the cord, the results are different from compressing a nerve root, because the cord contains all the nerve roots that pass through that section, okay? So we'll talk about that when we get to the diagnosis that I called myelopathy. Okay, so the next diagnosis is then cervical radiculopathy. So this term basically defines pain going down the arm, right? So it can come from a number of different things. Classically, it means that the nerve root is irritated and or compressed by one of several things: a herniated disc, a bone spur in the wrong place, meaning in the back of the canal, or both, which is what is called a disc osteophyte complex. Okay, so you may feel neck pain because the disc structure is disrupted. You may feel radiating arm pain, more so in this case because that's what this diagnosis is. Okay, and then you may have signs of nerve tension. Okay, and what do we mean by that? Well, this disc is pressing on this nerve root. Okay, let's say we're dealing with C3-4 as the level. So at C3-4, the C4 nerve root is what comes out. So you're pushing on the C4 nerve root. The C4 nerve root innervates an area of your body right here along your shoulder. Okay? So if you have neck pain going right in this area, and we saw a disc herniation at C3-4, we can kind of match things up. Okay? Same goes for C4-5. It would be hitting the C5 nerve root. And you might have pain going down here on the outside of your arm. So what a nerve tension sign means is that there's some pressure on this nerve, and if you raise your hand up above your head and hold it in this position, you then are relieving the tension on that nerve. And as a result, if you get relief of the pain in your arm, then that fits with the fact that there's pressure on the nerve. Does that make sense? Okay, so I put it in here. When I place my arm over my head, it feels better. Okay, now nerves that come out are responsible for 1, motor function, right? Your muscle's ability to do things. 2, sensation, okay? So they also carry the ability to feel in specific distributions. So as a result, if there's pressure on the nerve, you may have numbness and you may have tingling, okay? And then sometimes people say, well, I feel really weak in my arm. My biceps feels really weak. But when I objectively examine them, okay, I come up to them and I stabilize their shoulder and I say, pull your arm up towards your face. I resist them, and they can give me a decent amount of resistance. Well, then that in case, objectively from my perspective, from an exam perspective, they have full strength. But subjectively, the patient still feels weak. So those are important because it may mean that the disc is there pressing on the nerve. It's not causing enough pressure to eliminate the motor function, but it is definitely causing a sensation of pain. Okay? All right, so then the next diagnosis is spondylotic myelopathy. Basically what this refers to is compression of the cord. Okay, so typically this diagnosis comes from the disease process. So I'm going to explain the disease process a little bit, like spine disease or, like I said, degenerative disc disease. So the way we think about this is basically the disc sits in the front, right? You load the disc by doing normal activities. Over time the disc breaks down and it starts to bulge, and it bulges back in towards the spinal cord, right? If you get enough compression on the spinal cord, then you can get this diagnosis called myelopathy, and there are classic symptoms that go with it, okay? So questions I will ask my patients are, do you have difficulty? Well, basically it runs into difficulty with fine motor coordination. So do you have difficulty buttoning your shirts? Do you have difficulty opening a jar? Do you have difficulty turning the old style door handles like the one on that door? Okay. Have you noticed there's a sort of decrease in your overall penmanship? Or are you just not able to write the same way you were able to write before? Okay. And then most importantly, have you noticed a loss of balance, in the way that you ambulate and walk? So those 5 things are good screening signs for somebody who might have cord compression. Okay. Then when I do my exam, I also look out for specific things, such as their reflexes are hyperactive. Okay. When I test for specific reflexes, their fingers may contract like this, and all those things point in the direction of myelopathy. Okay. The reason why myelopathy is such an important diagnosis is because once you start to have cord compression, there's no way to predict how quickly your fine motor coordination will decline. Okay. And so in some people's eyes, cord compression is viewed as an emergency. Well, it's a relative emergency, okay? Because when we've looked at patients over time with this diagnosis, what we found is they sort of, over time, they follow a stepwise course, okay? And what that means is they may be stable for some time, then they hit that point where they fall down that step, okay? We don't know how far that fall is. We don't know what that means in terms of what coordination they'll lose, and then you restabilize again. So the goal is to find these people early or diagnose them when you can, because then you can intervene and preserve them at that higher level function. Okay? So that's why it's an important diagnosis. Anytime you have cord compression, it becomes important. Obviously, if you go to the extreme of that, of cord compression present for a long time, well, you can be paralyzed, right? So when people have this diagnosis, some people educate that, okay, listen, if you have a lot of compression on the cord, if you get into a catastrophic accident of some kind, like a severe accident, okay, severe car accident, and it results in the disc coming out more, you could potentially be paralyzed, okay? And so it's all about making the patient understand where they sit on that step ladder. If they've already declined significantly, meaning their function is not good and they're down about halfway already, then you probably want to intervene and stabilize. On the other hand, if they've only got 3 out of 5 signs, their fine motor coordination is actually pretty good, but they've got a big disc herniation sitting in the canal and compressing the cord, then you may be able to wait and not do anything with the understanding that you're at risk if something catastrophic were to occur. Okay? All right, well, obviously if you have trauma in the neck, that can cause pain, right? So things like fractures, common ways to get those are diving accidents, skiing accidents, and car accidents, where the vertex of your head hits something powerfully and the energy is transmitted through the neck. Okay? Clearly, if you have a fracture in the spine, you'd either pick it up from the x-ray or probably the CT scan when you were in the emergency room being treated. But what do you feel? Well, obviously pain. Okay? You may have a sensation of instability depending on how severe the accident is. And if you get any of these findings, then you should get evaluated immediately, especially if you had a recent accident. Okay, well, sometimes tumors can also occur in the neck. Okay, they can occur from the disc space, that can be an infection, or they can occur in the bone as well. If it occurs in the bone and results in cord compression, then the same kind of signs that we talked about before can happen, right? Like fine motor coordination difficulty. If the tumor's out towards the side and compressing only a nerve root, then maybe you have only pain going down the arm and numbness in the same distribution and weakness of a specific muscle group. Okay, so, but classic findings for somebody who may have a tumor in the neck include classically weight loss that's unplanned, nighttime pain that wakes you up, and pain that's just unremitting. It seems to never, ever, ever be able to go down with anti-inflammatory medications, common things like physical therapy. You just can't get a hold on the pain, and it's severe. So then you start to worry about things like tumors. So I mentioned unremitting neck pain, nighttime pain that wakes you up from sleep, weight loss, signs of cord compression, or arm pain. Okay, some people in the community have already had a fusion in their neck. okay? And they say, well, I had the fusion, I treated the problem in my neck, why am I now getting neck pain? Why am I now getting arm pain? Well, what we now know from studying patients who've had spine surgery already is that there is a diagnosis called adjacent level disease, okay? And what it means is that when you fuse one segment of the spine, the segment above and the segment below are directly impacted by the fact that one level is fused. Okay, so what do I mean by impacted? Well, just like at this level where you had a fusion and took the disc out, put a graft in there, and then put a plate up front to fuse it solid, there's still a mobile unit here and a mobile unit here. There can still be motion through those areas. There's a naturally preserved disc. Well, obviously, if you fuse this segment, and this segment are now going to take on more load, right? Because the load sharing is decreased. So there's a biomechanical difference in the environment. Secondly, there's also a hereditary component to this. Some people, and they've now isolated to genetic inheritance, are predisposed to break down at the next level if they have one level fused, okay? You don't know it ahead of time. There's no genetic screening for it at this point. But basically, as you follow those people after their surgery by x-ray, they more quickly break down than the person next to them if they were to have a fusion, okay? So now we know it comes from two things. One, some of it is biomechanical. Two, some of it is hereditary. So it's difficult to predict, but it is an important thing to keep in mind, especially for patients who've had surgery before. You don't want to think that, oh, just because I had surgery and I treated one level, my problem will never come. There can be other levels that can be involved. Okay, so the classic story is that, well, I felt great relief of my symptoms after my surgery for 5 years, okay, 10 years. Then suddenly the pain returned. And that's the point at which you should at least get an x-ray to look at the spine, whether it's your neck or your back, to see how things are looking, make sure the structure is intact. Okay, and then of course, depending on where the pain is or where the breakdown is, where the disc protrusion is, where the instability is, you may have associated neck pain, arm pain, pain going down the arm, or signs of cord compression. All right, so how do we suggest treating or managing back pain when or managing neck pain when it happens? So there's basic means to treat these things, which everybody should be aware of. So one is anti-inflammatory medications. So oftentimes when people come to the office, they say, I have had neck pain, it's been there for